Imagine sleeping for days, even weeks, waking only to eat or use the bathroom, then drifting back into deep sleep. When you wake, the world feels strange, your memory is hazy, and life seems to have moved on without you. This is the reality for those who live with Klein-Levin syndrome, or KLS, a rare and mysterious neurological disorder also known as the Sleeping Beauty syndrome. In today's video, we'll explore the history, epidemiology, causes, symptoms, diagnosis, treatment, and prevention of this fascinating yet devastating condition. Klein-Levin syndrome was first described in the early 20th century. In 1925, Dr. Willy Klein, a German neurologist, documented a group of patients who experienced recurrent episodes of excessive sleep lasting several days, along with behavioral changes. Later, in 1936, Dr. Max Levin, a New York neurologist, expanded on Klein's findings, describing cases that involved compulsive eating and sexual disinhibition. In recognition of their combined work, the disorder became known as Klein-Levin syndrome. Despite being identified nearly a century ago, KLS remains one of the least understood sleep disorders today. Klein-Levin syndrome is extremely rare, affecting approximately 1 to 5 people per million worldwide. It predominantly affects adolescent males, though females can also be affected. The average age of onset is between 15 and 20 years. Episodes can last days to weeks, and the condition can persist for 8 to 14 years before gradually resolving. Interestingly, episodes may occur once or twice a year, often triggered by factors such as infections, stress, alcohol, or sleep deprivation. The exact cause of Klein-Levin syndrome is still unknown, but several theories exist. 1. Hypothalamic dysfunction. The hypothalamus regulates sleep, appetite, and body temperature. Brain imaging during KLS episodes has shown reduced activity in this region, suggesting a temporary dysfunction. 2. Autoimmune theory. Some researchers believe that KLS may follow an infection, with the body's immune response mistakenly targeting parts of the brain. 3. Genetic predisposition. Although rare, familial cases have been reported, indicating a possible genetic component. 4. Neurological abnormalities. Functional imaging studies, such as PET scans, have shown decreased metabolism in the thalamus, frontal and temporal lobes during episodes, which might explain the cognitive and behavioral symptoms. However, there is no single known cause, and the syndrome likely results from a combination of factors. During an episode, individuals may sleep up to 18 to 20 hours a day. When awake, they often appear confused, disoriented, irritable, or childlike. Common symptoms include hypersomnia, excessive sleep lasting days to weeks, cognitive disturbances, memory loss, confusion, difficulty concentrating, behavioral changes, irritability, apathy, or hypersexuality, hyperphagia, compulsive overeating, depersonalization, feeling detached from reality. Between episodes, patients are completely normal, functioning fully with no symptoms. Episodes can severely disrupt school, work, and relationships, leading to social isolation and emotional distress. Diagnosing Klein-Levin syndrome can be challenging, as there is no specific test. The diagnosis is made clinically based on recurrent episodes of hypersomnia and behavioral changes, with complete recovery between episodes. Doctors often perform tests to rule out other conditions, including polysomnography, sleep studies, EEG, electroencephalogram, to rule out epilepsy, MRI or CT scans to rule out brain lesions, blood tests to exclude infections or metabolic disorders. The International Classification of Sleep Disorders, ICSD-3, provides diagnostic criteria for KLS. At least 2 recurrent episodes of excessive sleep lasting 2 days to 5 weeks. normal alertness and cognition between episodes, associated cognitive, behavioral, or eating disturbances during episodes. There is currently no cure for Kleine-Levin syndrome. Treatment focuses on symptom management and episode prevention. Stimulants such as modafinil or amphetamines may reduce sleepiness, but they do not prevent episodes. Mood stabilizers like lithium or carbamazepine have shown some success in reducing the frequency and duration of episodes. Antipsychotics or antidepressants may be prescribed if mood or behavior is severely affected. Supportive care is crucial, ensuring patients are safe, hydrated, and well-nourished during episodes. Family support and patient education play a huge role in managing the condition. Unfortunately, because the cause of Kleine-Levin syndrome is not fully understood, there is no guaranteed way to prevent it. However, patients are advised to get adequate sleep, avoid alcohol and recreational drugs, manage stress, and recognize early warning signs of an upcoming episode. The prognosis is generally favorable. Most patients eventually recover completely, though it can take a decade or more. With each passing year, episodes tend to become shorter, less frequent, and less severe.